Hello, and welcome to Your Health Matters with Marshfield Clinic. I'm your host, Laura Kibbel. I'm thrilled to bring to you today two experts in lung care and treatment. Please welcome Dr. Abdullah Al Twal, Pulmonary and Critical Care Intensivist, and Jackie Pfeifer, Pulmonary Nurse Practitioner. Thank you so much for being here today with me.
Thank you, Laura. It's a pleasure to be here.
Yes, I'm very excited to talk with you and hopefully learn a lot about the care that we provide our patients when it comes to lung disease. But before we get started, I'd love to hear and learn more about both of you. So if you wouldn't mind telling me where you grew up, where you went to school, received your medical training, and ultimately what brought you to Marshfield Clinic. Would you like to start, Dr. Al Twal?
Yeah, sure. Yeah. So I was born and raised overseas in Jordan, and that's where I grew up and went to medical school. After I graduated school, I moved to the States and I landed on the East Coast. And that's where I did my residency training in internal medicine. I did it at SUNY Upstate University Hospital in New York. And then I moved to New Jersey, where I did my subspecialty in pulmonary and critical care medicine. When I was in New Jersey, I came to find an ad for the job here at the Marshfield Clinic online. And I was talking to one of my attendings who worked in Wisconsin and Milwaukee previously. And he told me the clinic has a great reputation. He encouraged me to apply for the job. I applied, came here for the interview, and then just had a great feeling about the place, about the people. Within a week, I signed the job and I moved to the great state of Wisconsin.
Wonderful, wonderful. So how long have you been here with us now?
6 years now.
6 years. So what do you think of Wisconsin?
I love it.
Do you?
Yes.
The weather and the changes in the seasons and all of the things that go with it?
All of that. Yep. The beer, the cheese curds, all of that.
Excellent, excellent. We are so happy to have you here with us. So thank you for choosing Wisconsin. So Jackie, tell us about you.
So for me, I lived a lot of different places, but I would say I mostly grew up in Vermont, and so I lived there. Came to Wisconsin when I was 19, went and got my nursing degree in Eau Claire, and have been a registered nurse for 25 years now. I worked in the ICU, and then I ended up going for my advanced practice degree as a clinical nurse specialist, so I'm duly prepared both as a nurse practitioner and a clinical nurse specialist. I have been an advanced practice nurse now since 2007.
Wow.
So I've been in pulmonary for the last 14 years.
Okay.
So I very much enjoy what I do, and I've been in Wisconsin now for 26 years, longest I've ever lived anywhere. So I think maybe I can call myself a Wisconsinite now.
Absolutely. We welcome you with open arms.
Thank you.
So I'm really excited to have the discussion today because I think, lung disease is something that everybody knows someone that's got some sort of lung disorder, lung cancer, a disease, and there's so much to talk about. But before we get into the meat and potatoes of what we're going to discuss today, and can you tell me what exactly is a pulmonologist? What is it that you do and treat patients for?
Right. So as a pulmonary and critical care physician, my job works in two interconnected fields. So as a pulmonologist, I diagnose and treat diseases of the lungs and breathing, such as asthma, COPD or emphysema, lung nodules, lung cancer, pneumonias, lung fibrosis. Additionally, I do procedures in the airways like bronchoscopy, where we diagnose lung cancer, different types of cancer, infections, or inflammation. On the critical care side, I work in the intensive care unit, taking care of extremely sick patients, like those who need ventilators, or those who need medication to support their blood pressure, or they need any type of advanced invasive monitoring because their organs are failing. So my work varies from managing everyday breathing problems to providing life-saving measures to the sickest patients in the hospital.
It's really unbelievable. And for me, seeing it personally from, a clinic patient, you're one day you're seeing patients in the clinic, the next day, you're saving lives in the ICU, the buildings are connected, you're going from one department to the next, and it's just really remarkable work that you do. So I just really want to thank you and your team for the care that you provide our patients. It is unbelievable to see the type of care that you provide, and frankly, the lives that you've saved over the years. So I just need to make a point of saying that.
Thank you.
Yes. So Jackie, you, what do you specialize in the pulmonary department? Are there certain types of patients that you see, or can it vary depending on what they need to be seen for?
So it can vary a little bit, but the majority of what I like to see is COPD. I love my job. Now, COPD is chronic obstructive pulmonary disease. It is a chronic progressive disease that unfortunately there's no cure for, but however, we really strive to try to treat these patients so that they have the best days for as many days as they possibly can. So we really try to take that holistic approach of making sure, are they moving okay? Are they eating okay? Do they have enough resources to get their medications? So I take a lot of that nursing base information of what I've done for the last 25 years and really apply it to a medical model of how can I make these patients have the best quality of life for as long as we can, because that's what life is about. That's what we really strive to do. But I see other things, asthma, lung cancer, nodules. There's some different things. So everybody's a little different, but I really love seeing the COPD patients. I try to keep them out of the hospital as much as possible, but it's a great thing.
Yeah, and I can also say, for anybody that's got COPD, they know Jackie. And you have been such a constant for those patients, and you're exactly right. You're taking the holistic of your nursing training, into that practitioner where you're looking beyond, the medication, but you put so much into their quality of life and what are the things that they need to stay at home as long as possible. And so thank you for all that you do, because it's a lot of work, and these are very sick patients, and and you do an amazing job. So thank you so much. For the focus today, I'd really like to talk about lung tumors, lung nodules. Can you tell me a little bit, Dr. Al Twal, of what is a lung nodule or tumor, and how is that ultimately detected?
Okay. Yeah. So a lung nodule is a small growth in the lung that measures 3 centimeters or less. Lung nodules are extremely common in all adults who get some form of chest imaging, whether it's a chest x-ray or a CT chest. Up to half of all adults will end up having a pulmonary nodule. Fortunately, the majority of those nodules are benign. Benign means that they're harmless, whether they're related to old infections, fungal infections, previous trauma, but there is a small percentage of those nodules, up to 5%, they can be early cancer, which is why proper evaluation of those nodules is extremely important.
And why should someone be concerned if they have a nodule? I mean, can those turn into lung cancer if I have a nodule and it's non-cancerous? Could it eventually turn into cancer? What type of following do you have to do with those type of patients that have lung nodules?
Right. So we take into consideration multiple factors, like the patient's age, comorbid conditions, risk factors for lung cancer, which we will come into later. And based on all of those factors that we take into consideration, then we make a determination of how to proceed forward, whether someone is considered high risk, intermediate risk, or low risk of developing lung cancer.
So you did mention those risk factors. Jackie, can you talk a little bit about what are risk factors of developing lung cancer? I think, we all know smoking is certainly a high risk factor, but are there other things out there that also put someone at risk?
Sure, and so you're right. Smoking is by far the most commonly known cause of lung cancer, but there are also people out there who've never smoked in their entire life and have developed lung cancer. So there's things like your genetics will make a difference in this. Radon is prevalent in our area. Just because of how close the water table is, in your environment. And there's some things we just don't know why people end up with lung cancer. And so it's really important to get that screening done if you are at risk so that we can prevent things in the future.
So you mentioned radon, and I think that's something I want to talk about, because I know people, for those that might not know exactly what that means, people say, I got to check my home for radon if I'm going to put it up for sale. Or what does radon do that could impact lungs of people?
Okay, so I'll start by defining radon. So radon is a naturally occurring gas. It happens or it comes from the breakdown of uranium. So it is radioactive. Radon, we don't smell it, we don't taste it.
Mhm.
So just like Jackie mentioned, it can actually seep into the house from the ground. And then through inhalation, once we inhale radon, this is how the effect gets. And to Jackie's point, radon is considered the second leading cause of lung cancer after smoking, and it is the leading cause of lung cancer in lifelong non-smokers.
Wow, I did not know that.
Yeah, yeah, yeah. It is extremely important. Yeah.
So, what should people, I mean, should people be concerned in their homes, or should they be getting radon testing? Or, I mean, is there anything you can do to reduce the risk of radon exposure?
Yeah, so it is recommended to get any dwelling, any house tested for radon, and this can be done professionally, or for people, they can do it on their own by purchasing inexpensive radon testing kits. They can be even purchased online.
I did not know that. I think that is really excellent advice for people. So let's, if it's positive, then they can get professional people in to help mitigate that.
Correct.
And should they then report that to their doctor, to their primary care doctor, that I was positive for radon? Is this something I should be concerned about?
Yes, absolutely. It is something worth mentioning. Yeah.
Okay. So can we talk a little bit about the signs and symptoms of lung cancer? And is there anything that somebody, whether they smoke or they're exposed to secondhand smoke, is there anything they could say, geez, I should talk to my doctor about this. I might have some symptoms that could potentially turn in or are lung cancer.
Okay. So patients who have lung cancer, they can present with non-specific symptoms like cough, difficulty breathing, unintentional weight loss, or even coughing up blood. But unfortunately, those symptoms are really non-specific for lung cancer. And unfortunately, once a patient presents with some or all of those symptoms, it indicates that it is a disease that has advanced or that has progressed, which is why it is extremely important to raise awareness about lung cancer screening, early detection of lung cancer when patients are asymptomatic before they develop any of those signs and symptoms.
So you talk a little bit about the lung cancer screening. Who qualifies for that? What is the screening? What is the testing that is done? And when should that begin? We all know you have your first mammogram at age 4. Is that kind of a similar type of something that people should think about if they could, if they do have the smoking or the secondhand smoking or anything like that could expose them to the lung cancer?
Right. So lung cancer screening is done with a low radiation dose CT scan of the chest, where we take images of the lung to look for early lung cancer. The test itself is easy, quick, and painless. Those who qualify for lung cancer according to the guidelines are adults between the ages of 50 to 80.
Okay.
Who are heavy smokers, and this has been defined as people who smoked 1 pack per day for 20 years or 2 pack per day for 10 years, those who are still active smokers, or quit within the last 15 years.
So if someone gets a CAT scan and it's negative, does that clear them for life, or should they be having them on a routine basis?
Right. Once someone gets low dose CT scan or lung cancer screening CT scan, the report would classify them based on the risks.
Okay.
And let's say that the test was negative, then that patient would continue to get an annual CT every year if they fall within that criteria, which is the ages of 50 to 80 and the smoking history, whether they continue to smoke or quit within the last 15 years. So it's once a year test.
Wonderful. So I know everybody at home is probably thinking, well, my insurance isn't going to cover that. Jackie, can you tell us anything if this is something that is covered by insurance and what patients should do if they are worried that it might not be?
Absolutely. And so really it is a screening guideline, just like a colonoscopy, just like a mammogram. Honestly, I think it's the most painless and easiest test that anybody can do. It literally takes less than 10 minutes out of your day. But if you're worried that you may be a candidate, you should talk to your primary care, your pulmonologist, anybody who you're getting care from, and ask them if you're eligible for a low-dose lung cancer screening study. And they'll be able to kind of say yes or no, but the majority of patients are covered if they meet that criteria of 50 to 80 with an accumulated pack-year history of at least 20 years and are still smoking or have quit within the last 15. So you should bring it up to your primary care provider or whomever, just as a, hey, I heard about this, am I a candidate? Worst that's going to happen is they say no, right? And but if they say yes and we find something, we may have just saved somebody's life because we have maybe found something that wasn't going to have been found if we hadn't done that screening test.
Absolutely. So how many people I mean, is this something that is common? I guess, for someone, I honestly did not know that you should have the yearly CT scan, and I think that is incredibly important information. Do you feel like this is something that patients or people are aware of, or how common is this of getting this CT scan like a mammogram?
Yeah. So I'll tell you, I'll give you two sides of the answer.
Okay.
So number one is lung cancer is very, very common. It is the second most common malignancy after breast cancer in women and prostate cancer in men. On average, every 2 minutes, someone gets diagnosed with lung cancer in the United States. The concerning part about lung cancer is that it is the leading cause of cancer-related deaths globally and in the United States. Studies have shown that approximately 125,000 people lose their lives to lung cancer every year in the United States. Those numbers are staggering. Deaths from lung cancer are more than deaths from prostate cancer, breast cancer, and colon cancer combined.
Wow.
Yes. So definitely the numbers are staggering. The second part, which is very unfortunate, is that according to statistics from the American Lung Association, is that across the states, only 12% of those who are eligible they end up getting screened for lung cancer.
Wow.
Yeah.
Wow. Where does Wisconsin fit in that?
Yeah. So we rank slightly above average. Okay. We rank at 19% of those who are eligible, they get screened for lung cancer here in the state of Wisconsin. Slightly above average. We rank 12th among the states.
That still seems incredibly low to me.
It is.
I just feel like that is such an opportunity for people to really get a hold of, because if you can identify a potential nodule early enough, that, like you said, can be absolutely life-changing. So what can we tell patients to encourage them? I think, they don't want to go to the doctor and be told you need to stop smoking. It's kind of that. It's not a comfortable conversation. Any advice to our patient or to our friends at home about how we can encourage them to really have these open discussions and not be afraid to bring that up to their primary care doctor, that, the importance of, having this testing done and talking about and being honest about how much they're smoking or if they are smoking.
Sure. And I'd like to also just mention, this lung cancer screening can be done across our state and almost every Marshfield Clinic location that we have. And so if you're in Minocqua, you can get this lung cancer screening in Minocqua. If you're in Rice Lake, if you're in Marshfield, if you're in Neilsville, if you're in Stevens Point. And so it's not something that you just have to come to Marshfield for.
Sure.
And so it's really accessible all throughout our entire system and easily available. And not only that, but we have the capabilities to see these images and be able to make recommendations from Marshfield to people, who are living in Park Falls or
Yes.
Minocqua and
Yes.
such. So on that point, I just wanted to make that.
Mhm.
But I'm always encouraging my patients to be open and honest. We're all adults. Going to the doctor should be not necessarily a traumatic experience. It should be that we're working as a team. And if I don't know everything about what's going on in your life or what's driving you to keep smoking, then I'm not maybe able to care for you as the best way I possibly can. So tell me what you're doing, and it's okay. And let's work on a plan of maybe you're not ready to quit right now, but let's work on how we're going to cut back.
Sure.
How are we going to keep doing this every single time? I don't want you to be scared that I'm going to yell at you or to judge you. We're all adults. We all make our choices. I just want you to be the healthiest you possibly can.
Excellent. Thank you so much for that. So now I want to shift a little bit. We have a patient that has a nodule, and it's my understanding, and I'm excited for you to talk about this, of our state-of-the-art procedure that can really offer patients with a lung nodule some unbelievable ability to kind of find out what is their treatment moving forward. So can you talk to me about the robotic-assisted navigational bronchoscopy, what it is and how it works?
Right. So we established that a patient has a suspicious nodule, and that nodule needs to be biopsied. Up until recently, it used to be very challenging to biopsy those nodules. And again, they're very, very small. They're less than 3 centimeters in size. So the biopsy procedure used to be very challenging, almost impossible to some nodules. With the development of the robotic bronchoscopy, it has revolutionized what we can do as pulmonologists. And it is a cutting edge, minimally invasive procedure where we go in through the mouth into the windpipe inside the patient's airways. We use the patient's lung as a 3D map. We use that to help us navigate like GPS into the periphery of the lung, where we can use a robotic catheter that we guide it with great accuracy to reach the periphery of the lung, to reach those tiny nodules, where we can take biopsies with incredible accuracy and precision while the patient is under anesthesia. Here in Marshfield, we launched our robotic bronchoscopy program in April of 2025. And so far, we have had excellent results. We were able to help numerous patients get a diagnosis early to get them the right treatment that they need. So the development of the robotic bronchoscopy has revolutionized the way how we look at lung cancer. Today, the majority of lung cancer cases, they're diagnosed late when the outcome is unfavorable. And with this new technology, we're diagnosing patients very early when their treatment is much easier, when their survival increases drastically. To put that into perspective, the survival for very late lung cancer, it can be less than 10%.
Mm-hmm.
On the opposite end, very early stages of lung cancer, they can have a survival rate of above 90%.
Wow.
Mm-hmm.
Wow. So essentially what you're telling me is by doing this bronchoscopy, you weren't able to really know if a nodule was cancerous in the past? To know, because nobody wants to go through surgery unless they absolutely have to.
Right.
So you're telling me that now we can say, yes, this is or isn't cancerous, and then from there determine surgery and whatever oncological interventions need to happen much sooner than let's wait and recheck it in 6 months.
Right. There are few instances we would say that waiting would be reasonable, and that would depend on the patient's age, comorbid conditions, and the patient's wishes, among other conditions. But yes, right now with the robotic bronchoscopy, we're able to biopsy nodules that 10 years ago, it was almost impossible to get to.
Wow.
Mm-hmm.
That is unbelievable.
Mm-hmm.
I mean, that right there will save thousands of lives that we never would have maybe had that opportunity for in the past.
Right.
Unbelievable. How is it automatically if a nodule is seen on a patient's CT scan that they're going to have this procedure done, or is it dependent on what the radiologist sees in the CT scan?
So the radiologist, so a nodule can be picked up incidentally
Okay.
on a scan of the chest. If someone falls, breaks their shoulder,
Mhm.
gets an X-ray, can be picked up for any reason. Once that nodule is picked up, we suggest that those patients are referred to a pulmonologist where we evaluate those patients. We can actually risk stratify what is the possibility that this is cancer, and then based on that, then we can make a determination with the patient on how to proceed forward.
Okay, excellent. So a lot of discussion with the patient, really talking through what are the risks, what are the benefits, all of that. So that is outstanding. Um, After showing this episode, patients might think, geez, I really want to see a pulmonologist. I've got asthma, I've got I'm having trouble breathing, I am a heavy smoker, and I how do they get in to see you, Jackie, or you, Dr. Al Twal, or one of the other wonderful providers that we have in pulmonary, the pulmonary department? Is that something they need to be referred by their primary care provider, or how would they get in contact with someone in your department?
So ideally, we'd like the referral to come from primary care, but patients can self-refer if they so choose for. But we like the referral to come from primary care just so primary knows, because we
Sure.
kind of believe primary should be captain of the ship, and
Yes.
they should be helping to know what's going on with the patient. But once that referral comes in, we might do some breathing tests on the patient to see, what their level of lung disease is so that we can diagnose if it's COPD, is it asthma, get them on the right medications. And then, once they get in, they establish with us, and we try to make sure that they're living their best life in regards to their lung health.
Sure, sure. And do you feel, one more question, do you feel like medications have advanced over the years on treatment of asthma and COPD? Do you feel like we're making some headway there?
So when I first started, it was Advair and Spiriva
Yeah.
and prednisone, and that's
Yes.
basically all you had to manage anything. And over the years, it has just exploded in terms of different medications. And so the nice thing about our department is we also have a pharmacist that works with us, so that if you say, hey, this isn't covered or whatnot, that pharmacist also can help us and say, hey, maybe this one's covered, or hey, maybe that's a side effect of that inhaler, let's try something else. And so it's a really great service that we have.
Wonderful.
But yes,
Wonderful.
lots of new stuff.
Yes, yeah, that's one thing we can all agree on is medicine is evolving at a pace we can't even possibly imagine, but how wonderful for our patients, and to know that they have so many options to help treat their lung conditions is wonderful. I can't thank you both enough for being here today. I learned a ton, as I always do when I meet with the wonderful doctors and nurse practitioners that we have here. I appreciate your time, and I think everyone will come away knowing, one, don't be afraid to talk to your primary care doctor. If you are a smoker or you meet that criteria, please get your CT scan annually if you meet the criteria, and know that we are here to help you if anything comes back, and we'll do everything we can to keep you as healthy and happy as long as possible. So thank you, and thank you everyone for joining in today. I wish you all a very happy holiday and health and happiness in 2026. And until we see you again, stay well, my friends.